My name is Nicolas van Mieghem from the Erasmus University Medical Center in Rotterdam, and I will be chairing this session focusing on subclinical transcatheter valve thrombosis. So let's dissect the topic a little bit, and I'll do this together with my two friends and colleagues, Professor Joël Keffer from the UCL in Belgium and Professor Christian Hengstenberg from the University in Vienna. Basically what we want to do is we want to set the stage by briefly walking you through how we identify HALT and RLM. HALT is hypoattenuation leaflet thrombosis, and RLM is reduced leaflet motion. Then we will move on to try to understand what is the clinical impact of this CT observation. And finally, we'll also give an update on antithrombotic strategies to approach HALT and reduced leaflet motion. Basically, this is a meeting where imaging meets pharmacotherapy, and that is why we have a double sponsor. We have P Medical from the imaging point of view, and we have Daiichi Sankyo from the pharma point of view. I think the entire story of HALT started almost a decade ago with this publication in the New England Journal. This was coming from an observation in one randomized controlled study and two prospective registries, where all of a sudden they identified by CT scan leaflet thickening. We were unaware what the pathophysiology was, what the mechanism was, but at least it raised a lot of concern, and it even resulted in the temporary hold of that randomized controlled study. In the subsequent years, we started to realize that this incidence of HALT was determined by antithrombotic therapy. Patients on vitamin K antagonists or non-vitamin K antagonists were experiencing less HALT than patients who were receiving single or dual antiplatelet therapy. And also of interest, there was no difference in the incidence of HALT between patients on single versus dual antiplatelet therapy. So antiplatelet therapy does not seem to affect HALT. Oral anticoagulant drug therapy seems to affect HALT. But we'll get to much more details later in this session. So with that, I finished already the introduction, and I'll go to the next presentation. And that is a practical guide to the CT diagnosis of HALT and reduced leaflet motion. My conflicts have not changed. And from a pathophysiology point of view, I think it is important to realize that what we are doing with a TAVI is different from what a surgeon does. The surgeon excises the valve and and sutures in a new valve. What we are doing with a TAVI procedure is we are pushing aside the native leaflets and we're implanting then a new valve, but we are basically creating a new sinus. This neosinus, that is a place where there are different flow patterns, vortical flows. These flow patterns result in stasis of blood, and the stasis of blood can result in the thickening of the leaflets. Now, thickening of leaflets by itself may not be a problem, but this thrombus may trigger an inflammatory response, and that inflammatory response may eventually result in calcium depositions. That is the reason why somehow we are a little bit excited and a little bit concerned with an observation of HALT by CT scanning. But for now, there has never been proof that there is a direct link between HALT and, for instance, valve durability. But there are reasons to believe that HALT is something real and that it does create calcification that is different from conventional structural valve degeneration. When we see structural valve degeneration under the microscope, we will see calcium in the medial layers of the leaflets. With HALT, you will see the occurrence of calcium on the aortic side of the leaflet, so very superficial. So it's a different pattern. Whether it will result over time in structural valve degeneration or a specific type of structural valve degeneration, we don't know. Now, a couple of facts. Is it common? It's fairly common. Up to 30% of the patients receiving a TAVI valve will get or will have HALT at some time after the procedure. It is more frequent, or it seems to be more frequent, with balloon expandable valves as compared to self-expanding valves. It is less frequent with patients on NOAC or vitamin K antagonists. And what happens when you make the diagnosis of HALT? Well, it can go either way. It can resolve in the minority of cases. It will, it will have a spontaneous resolution in up to 50% of the cases. There is progression to more clinical, or it can become clinical in up to 15% of the patients, or it remains stable over time in the remainder. And NOAC therapy or vitamin K antagonist therapy may help in resolving the issue. So what about the diagnosis? It is a CT diagnosis, and in the Thorax Center we typically rely on the Trimensio software to do our pre-procedural planning, but we also use CT during follow-up. It is not our default follow-up. We don't do CT follow-up in all our patients, but within the context of trials, obviously we have a series of patients who had follow-up CTs, and then if there is HALT, this is what you can observe. You see these black spots in the short axis view, and in the long view you can follow the leaflets, and obviously you're not supposed to see these black thickenings. That is not normal, and that is the HALT. Now I hope this can play. Yeah, it plays. So in the short axis view, this is how it looks like. You can make and in the long axis view, you can then really appreciate also the movement. So you can have HALT with normal movement, you can have HALT with reduced leaflet mobility. And the way that you appreciate the leaflet mobility is in the long view. Whoops. Okay, and how do you classify HALT? Well, there is this classification grade up to 4 grades. If it's less than 25% of the length of the leaflets, and it always starts at the base of the leaflets, it's a grade 1. If it's more than 75%, it's a grade 4. In terms of leaflet mobility, you have basically more or less the same classification. If the immobile part of the leaflet is only at the base, it will be grade 1. If it is extending to the middle, it becomes grade 2 or grade 3. And if it goes beyond 3/4 of the leaflet, so if really you get a frozen leaflet, then you have grade 4 reduced leaflet mobility. What are the predictors? We have patient-specific, device-specific, and procedure-related predictors. The patient-specifics, it's more common in men. Also in obese patients, patients with larger sinuses, in bicuspid valves, patients with low flow, low gradient aortic stenosis, and in patients with a hypercoagulable state. There are also device-specific criteria. The intra-annular functioning valves, so not only balloon expandable valves, but also, for instance, the Navitor or Portico valve, seem to have a little bit a higher occurrence of HALT than the self-expanding supraannular functioning valves, the Accurate valve or the Evolute valve. And it is intriguing to, I don't know whether you heard the results, the 5-year follow-up data of the SOLVE-TAVI trial. This is a randomized controlled trial by our German colleagues comparing Evolute R versus SAPIEN 3. Well, out to 5 years, there was no difference in terms of clinical outcomes, but they did see more strokes. The stroke difference was, I think, almost 10% in favor of the Evolute valve. And so why would that be? Why would we see more strokes over time, more neurological events with the balloon expandable valve? Well, apparently, this could be explained by this occurrence of HALT that then progressively develops, becomes bigger, and then starts to create or starts to become a source for embolization. But that is an hypothesis, never been proven, but you start to ask yourself, why are we seeing these observations in, for instance, the SOLVE trial? Also bear in mind the SOLVE trial was not powered for that endpoint at 5 years, so this is just, it can still be a play of chance. But at the same time, it's also, I would not ignore it, and I do believe that we might have a correlation or a relation with HALT. What is the fate of HALT? I briefly discussed it already. We have some data from the low-risk trials. This is from the Evolute low-risk trial. There was a subset of those patients who were followed up by CT scanning, and the interesting part is obviously that you then have HALT in surgical patients and in TAVI patients. There is no difference in the incidence of HALT between surgery and evolute valves. Not at 30 days, also not at 1 year. What happens then with the patients who were identified with HALT? So the neat part is patients had follow-up CTs at 30 days and at 1 year. Well, if you look at the TAVI patients with HALT, there were 26 patients with HALT. Well, 15 patients still had HALT at 1 year. 11 patients had no longer HALT. And the interesting additional aspect to these studies is HALT was not a trigger for oral anticoagulant drug therapy in those trials. So this was spontaneous resolution of the leaflet thickening. Very interesting. In the surgical arm, you had somewhat a similar finding. So of the 18 patients with HALT, 13 patients were still having HALT at 1 year. 5 patients had more or less spontaneous resolution. Also of interest, the patients who did not have HALT at 30 days, well, 30 patients had HALT. 30 patients had HALT at 1 year, and of the surgical patients, 20 of the 98 patients had HALT, developed HALT between 30 days and 1 year. So that tells you that it's still unclear what triggers the occurrence of HALT. We do have some pathophysiological hypotheses, but there are probably multiple mechanisms. Now let's look at the data from PARTNER. This is, again, a low-risk trial comparing TAVI with the balloon expandable valve versus surgery. Somewhat a different story. Here we see more HALT in the balloon expandable TAVI arm as compared to surgery. And this definitely is a different observation than what we see in the Evolute low-risk trial. Then again, what's going on with HALT over time? Well, again, we have the CTs at 30 days and at 1 year. Of the patients with of the 20 patients with HALT at 30 days after TAVI, half of them had spontaneous resolution at 1 year, half of them still had HALT. In the surgical arm, there were only 5 patients with HALT, and at 1 year, only one of those still had a HALT at 1 year. So basically, always be very careful with the cross comparison between these two trials. We are always triggered to do that, but you have to be very careful because just focus on the surgical group. Well, it seems that, well, first of all, HALT was not so common in the surgical arm than the surgical arm in Evolute low risk, and also HALT seemed to resolve spontaneously more often with surgery in the PARTNER trial than in the Evolute low-risk arm. So always be very careful with the cross-comparison. This is the last slide that I wanted to show for this talk. This is a study data from Minneapolis. They had 79 patients who had HALT by CT scanning. They did follow-up CTs in 81% of these patients. And then again, it's interesting to see what's going on, what's happening when you do change your antithrombotic therapy. So this, in these patients, the investigators were triggered and they changed antithrombotic therapy. So the majority of the patients received a vitamin K antagonist or a non-vitamin K oral anticoagulant drug. And then you see that most of the patients no longer had HALT during follow-up. So, and we will dive into that obviously later on during this during our session here. So the question is, should we take HALT and reduced leaflet mobility? Should we take it seriously? And then also, if we do see it by CT scanning, does it need to trigger an adjustment in our pharmacotherapy? So we will dive into that with the next two speakers, but maybe a first question to Christian. What triggers you to do a follow-up CT in your patients? Is it some kind of a clinical scenario, or do you have a protocol that you follow in Vienna?
Yes, it is a very, very difficult question, and I think you set the scene very nicely. We do routine follow-ups by echo. And if an echo gradient does increase, then we go for follow-up CT. So we could not do a follow-up CT on all and every patient. That would not be logistically and ethically probably not possible.
Yeah, I agree with that. I agree with that. So obviously that is an additional radiation exposure to your patient.
Right.
So you should discuss upfront that that would be in the context of some kind of research protocol if you do not have a clinical indication to do the CT. And I think there are two clinical indications. One of them is obviously when you see an increase in gradient by echocardiography. The other one is if you have a neurological event, obviously.
Right.
If a patient presents with recurring TIAs or strokes, that, at least in my side, would trigger a CT scan. But there's a question from the audience.
Yeah.
I just have a question regarding pharmacotherapy after finding out the patient is having a HALT. Whether vitamin K antagonist and Novax, which is better, and is there any data regarding that?
So you better hold that question because Christian is going to focus on that in like 20 minutes or so. Okay, Joël, do you have any protocol in place in your center, or is it more or less the same as what we were describing?
It is more or less the same. So the follow-up is clinical and echocardiographic. And in case of clinical problems, we do a CT, but we don't do a routine CT scan follow-up in the clinical practice, only in the situation of clinical research.
And for the interpretation of the CT scan, you rely on your radiologist, or you do it yourself?
I don't rely on the radiologist. I like to discuss with the radiologic team because they have, for sure, a better knowledge about the radiologic aspect of CT scan.
Yeah.
So, but could be a CT scan team or a team to evaluate the images. And this is so important to share with the team. And from my point of view, the cardiologist doing TAVI should be able to evaluate the CT scan imaging, for sure. Yeah.
So I agree with that. So I am 100% independent in analyzing CTs in the pre-procedural planning, but for the interpretation of HALT, it is more like a consensus with the radiologist. I have also the privilege to have a very engaged coronary and structural heart CT radiologist in my center, so that helps. So there is always then like a dialogue between the two of us. Yeah.
May I make a comment on the echocardiographic follow-up? This is somehow tricky because we know that if you have a small valve or small annulus, then there is a sort of a hold or any sort of problems will result in an increase of gradient. However, if you have a large annulus, you could even have one totally blocked leaflet without seeing a major increase of gradient. So that makes me a little bit unsure of whether or not, I mean, if you look to this specific phenotype, whether the echocardiography follow-up is well taken in order to see this follow-up.
I think that's a very important comment. So echocardiography by itself cannot be our go-to imaging modality for the diagnosis of this specific entity. You really need CT scanning, and you would miss a lot of those cases if you only rely on echo. That said, the triggers are an increase in gradient, but also some clinical triggers, for instance, systemic embolizations or neurological events. Okay, so with that, I think we go to the second question, and that is, should we take HALT and reduced leaflet mobility seriously?
So these are my conflicts of interest. So as you know, and explained by Nicolas just before, the beginning of the story of HALT is a patient included in the Portico ID study who underwent a CT scan because he was included in the scientific study. And Makar et al. Published this very nice picture with reduced leaflet motion, so RLM, and which was in fact renamed HALT, so for hypoattenuating leaflet thickening related to the CT scan appearance of this strange phenomenon. And as you can see, it was only seen in only one patient. The authors observed this HALT in all types of devices used in the study, even with surgical bioprosthesis. So a number of questions were raised by this incidental finding. What is the incidence of HALT and RLM? Is it restricted to TAVR, or is it observed after SAVR as well? Is it device-specific, or is it distributed equally among all bioprosthetic models? What is the natural course of these abnormalities? Is thrombus the causal mechanism? What is the clinical significance? And what therapeutic strategy should be adopted? And my talk will focus on the clinical significance of RLM and HALT. So this is really a strange phenomenon, as discussed by Nicolas just before. And one first message is that there is no strict relationship between the echo gradient and HALT. And you see how we can explain that. This is a model coming from the engineers using a benchtop hydrodynamic testing with a pulse duplicator model. And you can see on the right part of the slide here how we can use a forced closure of one and even two leaflets of a transcatheter valve, and it is not strictly associated with a high increase of transvalvular gradient. And as mentioned by Christian, especially in large anatomy, large annulus, it will be associated with only minor increase of transvalvular gradient, which can still stay in the normal range of the aortic bioprosthesis. So this is the reason why we can underdiagnose the HALT phenomenon using only the echo follow-up. A second paradoxical observation in this HALT phenomenon is the conflicting results between CT scan observation and clinical outcome of patients. You see on the left part of the slide this very nice illustration of Ole de Backer, illustrating how the CT scan outcome was much, much better in patients included in the rivaroxaban arm of the Galileo study as compared with patients randomized in the antiplatelet arm of the study. So in other words, you have less RLM and leaflet thickening among patients receiving anticoagulants. In this Galileo study, it was rivaroxaban, as compared with patients receiving only antiplatelet therapy. So CT scan is much, much better. But you know, everyone here in the room know that the general study was not good for the rivaroxaban arm. If you remember, when Galileo study showed that patients treated with rivaroxaban had a higher risk of death, thromboembolic and bleeding complications. So CT scan outcome was better, but clinical outcome was worse under anticoagulants. So this is another paradoxical phenomenon with HALT. So coming from these observations, several observational studies and registries were done to try to understand this mechanism, and one of the meta-analyses of these observational studies show a strong relationship between leaflet thrombosis and cerebrovascular events, mainly the TIA, but stroke as well, with no impact on death or myocardial infarction. But the problems, the methodological problems of the observational studies and registries are the variability of the timing of CT scan. So the time after the procedure was variable to do the CT scan follow-up because it was observational studies. And as mentioned by Nicolas, the HALT phenomenon sometimes recover, sometimes can reoccur spontaneously without any treatment. And the other limitation of the observational study is the lack of strict definitions. At that moment of the HALT analysis by CT scan, there was no core lab to define exactly with a robust method the presence and the characterization of HALT. So this is the reason why it's so important to look at the randomized studies, which are probably more reliable because they have a more robust methodology, especially in the definition of HALT and the presence of a core lab to analyze the CT scan. You see on the left the data of the CT sub-study coming from the Evolute low risk, showing that HALT is equally frequent after TAVR and SAVR, and the authors did not show correlations with valve hemodynamics and no clinical outcomes. But the follow-up is limited to 1 year. On the right part of the slide, you see the result of the CT scan sub-study of partner 3, showing something a little bit different, showing that HALT is more frequent after TAVR than after SAVR, especially at 30 days, so the difference is reduced at 1 year. There was no association with death, stroke, and MI individually, but pooled thromboembolic events are higher with stroke, TIA, retinal artery occlusion pooled together in the HALT group as compared with no HALT group, with a minimal increase of transvalvular gradient. So there is some small differences in the message provided by the two randomized trials, but once again, this is a short-term follow-up, 30 days and 1 year. So finally, what are the risk factors? What about the predictors of HALT phenomenon? So once again, coming from the observational studies, there is a meta-analysis showing that based on 7 observational studies, so more than 1,600 patients, a higher prevalence of leaflet thrombosis in intra-annular design. And to explain that, you see on the left part of the slide that the design of the prosthesis itself could have an impact on the HALT occurrence. You see on the left the intra-annular valve. The number 1 is the anatomical sinus. The number 2 is the neosinus created by the new valves, the intra-annular valve implanted, that create a larger neosinus than the supra-annular valve. And you know that the neosinus could be a zone for blood stasis and thrombus deposit. So based on this information, engineers work a lot in the companies to investigate the role or the potential role of the leaflets, and they analyze the leaflet's kinematics and the relationship on the blood stasis. And you can see here on these illustrations with balloon or self-expanding valve, the engineers analyzed where is located exactly on the leaflets the zone of absence of mobility, which are the region for thrombosis or thrombus deposit. So these leaflets mobility were improved now on the new systems and are still under investigation. Another aspect of the possible impact of the prosthesis design on the HALT is the stent frame geometry. And these data are coming from a nice series for one center showing that a non-uniform expansion of TAVI device, asymmetric expansion and or under expansion, resulting in frame deformation, is related to the occurrence of HALT. You see on the right part of the slide a very nice expansion of balloon of self-expanding valve with no HALT. And on the left part you see that an asymmetric or under-expanded platform could be related to the occurrence of HALT, and this is true for the SAPIEN and for the Evolute platform in this study. So is it the possible natural history of HALT? Nobody knows today, but this natural history, this graph, was suggested by the team of Rashid et al. From Australia. So if you compared the normal leaflet morphology, absence of HALT, with the hypoattenuated leaflet thickening, it could be, but I insist it's an hypothetic statement, it could be the beginning of the process of the reduced leaflet motion and then severe valve thrombosis with clinical leaflet thrombosis and risk of cerebrovascular events, and finally structural valve deterioration. It's hypothetic because today we don't know exactly the relationship between the imaging finding and the clinical outcome of patients, because there is a lack of long-term follow-up of patients with diagnosis of HALT during routine CT scan after TAVR. There is one paper, very, very interesting, coming from Germany, published recently by HANT, with a follow-up of more than 3 years among patients undergoing a TAVR, successful TAVR with no problem. They performed a routine CT scan 5 days after the TAVR, and among the cohort, 115 patients had early HALT but were totally asymptomatic. And they were followed during 3.25 years, median follow-up, and you see the results on the left part of the slides. So there was no association of asymptomatic HALT detected during routine CT scan early after a successful TAVR with the clinical events in this study, so no relationship with mortality or cerebrovascular events. However, the authors observed an association of HALT with hemodynamic valve deterioration. In this study, HALT was independent predictor of structural valve deterioration by multivariate analysis with a hazard ratio at 6. So to conclude, HALT is frequent, approximately 1/4 of patients at 1 year, but this is a dynamic process with a recovery in approximately 50% of cases. The impact on the outcome remains today debatable, especially on stroke and valve hemodynamics, and mechanistic insight into causative factors for HALT remains relatively limited today. It seems that there is an impact of the design of the prosthesis and the frame geometry on the occurrence of HALT. For sure, thrombus deposit is one of the key factors of the phenomenon. It's still today, HALT is an imaging finding with an uncertain clinical significance, but we should elucidate it, and this is the reason why we should continue to be busy with this phenomenon and to have a good understanding. So thank you for your attention.
That was an excellent overview, Joël. Thank you very much. We have a question, Andrea.
Thank you. So really interesting data. My observation regards a specific population, because Nicolas, you spoke about SOLVE-TAVI, but I would like to pose attention on Notion 2 trial, bicuspid aortic valve, because as you perfectly show in bicuspid, we know that stent frame under expansion could be more frequently than in tricuspid counterpart. So maybe the results can be the consequence of this process, and I'm asking if we have to pose more attention to an undersizing, so sizing the valve in a supraannular position to mitigate this important aspect, because when we speak about bicuspid aortic valve, we usually pose attention only to the use of cerebral protection, but maybe the mechanism could be another one. What do you think? Thank you.
So you're a very smart man. I had some similar notes that I made about Notion 2. So just for the audience, the Notion 2 results showed that in low-risk patients with an STS score of 1.1, mean age of 71 years old, there was no difference between TAVI with an evolute valve, I think, versus surgery. A quarter of the patients had bicuspid aortic stenosis. When they only looked at the patients with bicuspid aortic stenosis, there were more strokes in the TAVI arm, and that is a remarkable finding. Then the question is, and I haven't seen more granular data yet, were these events clustered immediately soon after the procedure? And that obviously would then be an argument to consider cerebral embolic protection. Or is it more later in follow-up happening? And then I think we might have some kind of pathophysiological mechanism that relates to HALT and this issue of leaflet thickening. So, but I think it is a very important comment. There is also new technology on the market. MyVal, we have seen the landmark trial. MyVal is a balloon expandable transcatheter valve that has more sizes available. So there are these so-called intermediate sizes. And you can already think that these intermediate sizes might be of interest, so that you can more size according one-to-one to the anatomy. What we're doing now with, for instance, a sapien, is that we would add volume to the balloon or take volume out of the balloon, but that will come with consequences, because if you take volume out of the balloon, the expansion of the valve frame will be suboptimal. It will not be expanding to its fullest, and that is associated with, for instance, HALT. So these are intriguing hypotheses, but I think more and more we are getting sensitive to this analysis. Christian, am I overthinking, or is there something here?
I don't know, but the point I see is that there are many variables that seem to influence the phenotype of HALT a lot. So when it comes to the valve itself, so you nicely showed that also the frame itself does play a role. Yeah. Then I think the leaflets themselves may also they are different. Yeah. Then the height of implantation is different. So if you talk about sinus and neosinus, this is something that is then also variable according to the valve type used and the implantation height and etc. So there are many variables, and the question is whether we see all HALTs that exist, or I guess that we are overlooking a lot. And then the next question I personally would have is about the timing. So when does it occur? When does it resolve? Or maybe it occurs, it resolves, and then we do an echo and follow-up, and we didn't see anything. So I'm a little bit puzzled about this phenotype, and therefore the clinical consequences that you elucidated to is of enormous value. And also, I mean, you could also argue, well, there is some HALT, but this is just a little scratch on the beauty of the valve, but there's no clinical consequences. So why do we care about it? And
Well, there are these. At this edition of PCR, you have these two trials that seem to suggest something, and you have to try to come with an explanation. And so far, the only explanation that I can have is must have something to do with leaflet thickening. And I wonder whether we need to get well, definitely we need to explore further and more systematically, because now the methodologies are all over the place. You had this German study doing CTs at 5 days, then you had the Evolute low risk and the partner 3 sub-analysis with CTs at 1 month. The numbers are all over the place, but that is because we don't know. So I think we have to become creative about designing a proper trial that would help us understand the phenotype better, but also to understand how we can modify and affect it. But there is a question.
Short one. In this foggy scenario, in which is really beautiful, we are speculating a lot, but actually we are not able to conclude. My question is, did you observe between men and women? Women are known to have more autoimmune process. Is there any difference in terms of HALT in women rather than in men? Thank you.
Some observational studies suggest that the HALT is more frequently observed in men. So men looks at risk factor, but once again, it's observational studies. So as mentioned by Nicolas, so the methodology to analyze the CT scan was probably not robust and strict, so I would be careful to make an absolute statement about that. And I totally agree that today there is a doubt, so nobody knows exactly what we should do, and we have to wait, I guess, the long-term follow-up of those patients from the German study and the Evolute and Sapiens 3 to have a better understanding. Yeah.
And to add to that, again, the data, so the indication that it's more common in men than in women, there are a lot of confounders there, because obviously in real life, in practice, it happens that we are implanting more balloon expandable valves in men than in women, and more self-expanding valves in women than in men because of the sizing issues and so on. But that affects, obviously, the occurrence of this phenotype. Anyway, I think we have to move forward. Thank you very much, Joël. So now it's my pleasure to present Christian Hengstenberg, and he's going to discuss pharmacotherapy to treat or to address in patients with HALT.
Well, thank you very much. It's a pleasure being here, and I think it's a very interesting discussion. And so we'll hop into this one. So I think many things have already been addressed, such as also the patient characteristics, so age, sex, history of events, such as thromboembolic events somewhere in the body. That is something that puts the patient at a higher risk. Then there are several comorbidities in the patients, such as kidney disease, AFib, cardiovascular risk factors, etc. Co-medication, such as antiplatelet therapy, is off note and needs to be taken into account. And procedural factors, as we discussed in part, that may be of interest for this whole story. We see that there is a balance or counterbalance of both stroke, ischemic events, and bleeding. And this is what we always try to balance, because otherwise, if that would not be the case, we would do anticoagulation in all the patients, and we would no longer meet us here in this very nice session, which would be a pity. But I mean, the bleeding risk is, as you can see, quite high. And if you look to these different trials in high risk, intermediate, and low, you see clearly that there is a stroke risk in those patients who have a high risk, and you see also that they have a very high risk for bleeding. We all know that we are moving now a little bit, towards the lower risk patients, so bleeding becomes a less of an issue. But still, this is something that we all know is of importance. Now here you see the 30-day data. If you look to 1 year, you see that there is a considerable increase in major stroke rate in the high-risk patients. In the low risk, it is not. But still, the bleeding risk is of note. Now, what is the timing of the bleeding events? If it is only at the moment of the procedure, we take care of that and then do the anticoagulation later and abandon the risk of HALT. But it's not the case. So we see that there are early bleedings and late bleedings, and we unfortunately cannot just abolish the bleeding risk totally after some time. And if you look now to the subclinical leaflet thrombosis issue, and this has been addressed already, you see that there are different data out there, and one has been alluded to is that with the 22% is a very high in one valve, and it is less so with other valves, but it seems to be there for almost every valve. We also had the comment on the type of valve. So there are different stent types, then there is the valve type is different, and a sort of expansion is different. All these things may have an influence on the occurrence of HALT. and also the need for anticoagulation as well as antiplatelet therapy. So this is a study that has come out of our institution and is a meta-analysis. And if you look to intraannular versus supraannular, that is also, I mean, we discussed this neosinus thing. There you see that the favor that supraannular valves seem to run a little bit better than intraannular valves. If you look to the occurrence of leaflet thrombosis in the presence of anticoagulation, that is clear that anticoagulation is favorable for preventing leaflet thrombosis as compared to no. And if you look to DAPT versus single antiplatelet therapy, there is a little bit, there is no clear picture, but if in some studies there was advantageous to have dual antiplatelet therapy as compared to single one. Now, these were registry data, and if you go to now randomized control data, there are a few studies out there, and one major point to address is that we do not have, in this set of data, there is no need of anticoagulation per se. So there is no anticoagulation atrial fibrillation or any other indication for anticoagulation. So the ARTE trial, the Popular TAVI trial, Galileo trial, and Atlantis trial. And I don't want to go too much into this detail, but just mention the advantages that are given then on the right-hand side of the slide. So in the ARTE trial, they say that monotherapy with aspirin is more advantageous as compared to dual antiplatelet therapy. The same is true for the Popular TAVI in cohort A. In the Galileo trial, you have the comparison between NOAC, rivaroxaban, as compared to dual antiplatelet therapy. And there, the dual antiplatelet therapy was advantageous as to the co-therapy of rivaroxaban in a lower dose as compared to and in combination with aspirin. And in the Atlantis, apixaban is the same, about the same result as the dual or antiplatelet therapy. Now, if you look to the different population, where you have the anticoagulation because of atrial fibrillation, so Popular TAVI cohort B, or the Atlantis first stratum, and there you see that in a Popular TAVI, VKA monotherapy seems to be more advantageous as compared to the combination with a clopidogrel. And in Atlantis, you see that apixaban is equal to a VKA. Now we have the envisage study. Nicolas and myself are members of the study group, and so in this envisage study, we see that edoxaban is non-inferior to NACE. But there is a higher rate of gastrointestinal bleeding if you treat the patient with edoxaban as compared to VKA. Now, what about the strokes after TAVI? And we just took advantage of looking into the database of the envisage. There were a total of 41 patients out of almost 1,400 that had an ischemic stroke. And if you look to the occurrence of the stroke, which is depicted on the right-hand side, you see that the stroke rate goes up continuously over the duration of 1 year or 2 years. In this is just a small information. We see over the time that edoxaban treated patients in green have a little less occurrence over the course of 1 year, until 1 year. Now, when it comes to dual antiplatelet therapy in these patients, again, these are patients with treated with anticoagulation because of atrial fibrillation after successful TAVI. You see that about 10%, that is on the right-hand side here, about 10% do have had a PCI. And because of the PCI, they get a certain anticoagulation or antiplatelet regimen. And you see then the timing here. And you see the timing is about 50% of the patients do get the TAVI in the range of 1 month to the successful TAVI implantation. So they do have usually antiplatelet therapy on board. If you look now to the adherence of these patients and the anticoagulation, then you see that something that we all see then on the right-hand side, patients after recent PCI and after 90 days, there is a drop in patients that who have this antiplatelet therapy. But still, after 3 years, there are patients who do have anticoagulation and antiplatelet therapy in these elderly groups. So that's really something. This is a 30% about. And if you look to those patients who do not have recent PCI, you still have patients with anticoagulation and antiplatelet therapy. So that's remarkable. So as a summary, I think that those patients who do not have indication for anticoagulation should be treated with a single antiplatelet therapy according to the data that are out there. And if, however, you have a recent stenting, you just behave as if you would have just normal stenting and continue then with a single antiplatelet therapy after your dual therapy is over. If you have the, on the right-hand side, if you have the indication for oral anticoagulation, for example, because of atrial fibrillation, then you do a oral anticoagulation according to your preference, NOAC or vitamin K antagonists. And if you have then additional coronary stenting, you just go with a dual antiplatelet therapy as short as possible. We actually do single antiplatelet therapy in those patients who have not a super high risk, and then continue with oral anticoagulation. Thank you very much.
So, Christian, and what then if you have the diagnosis of HALT in a patient where you see that the gradient is increasing? What is your policy?
Right. So again, we have to make the decision or the difference between those who are on anticoagulation and the ones who are not. So if these patients would, for example, not be on anticoagulation, I would put him on him or her on anticoagulation. If, however, he is on anticoagulation, then look what kind of anticoagulation. Is it a NOAC or is it a vitamin K? If it is a NOAC, then we would switch to vitamin K. If it is vitamin K, well, then look to the INR. If the INR is, somewhat sloppy, then you go for higher anticoagulation and see him or her after, 2 weeks or so again.
Yeah, so I have a similar policy. So in principle, if the patient is on a vitamin K antagonist for AF, your target is between INR between 2 and 3. If the patient had developed leaflet thickening on this regimen, I would increase the INR target and I would aim more for 3. So I would say then, okay, from now on, our aim is between 2.5 and 3.5, so that you would end up on average on a higher INR. Once you have established your therapy, Joël, and what is your follow-up scheme then? You bring the patient, what is your follow-up tool? Is it imaging? Is it, obviously it will be imaging, is it echo or is it another CT scan?
I would say for the clinical follow-up, we need echo just to be reassured about the reduction of the gradient for the patient. And the question, I have no answer about that, but can we stop anticoagulation safely among patients with HALT? Yeah. What about the risk of recurrence? Yeah. And this is a balance between the long-term anticoagulant therapy for those patients with the risk of bleeding, well demonstrated by Christian. Those patients treated by TAVR usually are patients at high risk of bleeding. And on the other side, if you left untreated a HALT with significant gradient, you will expose the patients to a structural valve deterioration. So it's really complicated.
So obviously when you have the luxury of having an increased gradient, then echo is the way to go to do the follow-up. And if you see that your gradient is normalizing, then you come to the point where you have to decide whether you continue or not. In my practice, it is we continue it at least for 6 months. And if there is no bleeding risk, if there is no high risk for bleeding, then we would recommend to continue it for life. Why? Because we have seen a recurrence rate of up to 30% in the patients after interruption of oral anticoagulant drug therapy. Yeah. Have you also noticed that recurrence rate?
Yes, it is very puzzling, and because, I mean, we think about the pathogenesis of HALT, and then with the anticoagulation you can lower it. It's abolished, and then usually we think that there should be endothelialization. There should be everything. You know, the valve should be better accommodated in its new home, and then. We think that with this endothelialization, probably you don't need it anymore, but in some patients you need it. And then it is of note, however, to see that there are some patient-related factors, as I tried to allude to at the very beginning, and so maybe there is something in these patients that need to be addressed. So maybe they have some sort of a hypercoagulative state. In which then is negative for their HALT situation.
Right. Question?
Well, I have a simple question. In our institute, I'm from the Brigham and Women's Hospital in Boston. In our institute, we diagnose many cases of HALT based on CT. So, is there any approach of triaging the patients, actually not to stop, but actually to start the anticoagulation or antiplatelets? It means if you have, for example, the degree less than 25% or 25%, but with high gradient or with a high risk, would it be different from if I have 75 but without gradient? Is there any consensus about the approach for this to start the medication? Thank you.
Yeah, I mean, if you are somewhat guideline-based or evidence-based person, then I have to say I cannot tell you anything because there is no good data about that. If you are an eminence-based individual, then I would say, well, go for anticoagulation, and whenever you see some sort of HALT, that would be my take. But I'm, just a. So it's not. There is no, at least to my knowledge. Maybe some other people know more about it, but I don't see that there is any sort of recommendation officially.
So there are multiple flavors to that question, right? So if a patient only has HALT but no reduced leaflet motion, and it's an incidental finding, I would not respond to that. I would just follow up the patients, maybe more closely. In principle, I do an annual echo follow-up. In that particular patient, I would bring the patient back at 3 months, and if then there is no change in gradient, it will be annually again. But there is another end of the spectrum. If a patient is hemodynamically unstable because of leaflet thrombosis, and I wanted to briefly mention that because we also sometimes face those kind of patients. The first thing that we do is we put the patients on heparin. But there is also a very interesting therapy now, and that is low-dose, slow infusion thrombolysis, actylysis. And that works very well. And so we have been using that not only in hemodynamically unstable patients, but also in patients where we do not manage, we are not successful in reducing the gradient despite optimal anticoagulant drug therapy for multiple weeks or months. And what you then need to do is it's 25 milligrams over 24 hours. So very low dose, 1 milligram per hour. Regardless of the body weight of the patient, and then you repeat the echo. If there is no effect of the thrombolysis, you repeat it. And so you repeat it until you see the gradients normalize. And so we have multiple cases now. It has been also published as a case report, and we are going to publish together on a state-of-the-art paper on the treatment of transcatheter valve thrombosis in JAK in the forthcoming weeks, where we will elaborate a little bit on that therapy. But it is very effective, and it is also safe. It's a safe approach. But you will end up doing 3 to 4 runs of this slow infusion, low dose actylysis.
But may I?
You use this regime, 1 milligram per hour at the phase.
Sorry?
How you decide to give the 1 milligram for each hour?
Yeah.
On what base? So that is if the patient is hemodynamically unstable, that is one. And the other one is if my therapy with anticoagulant drug is not successful in reducing the gradient.
My question is, why not 2 milligram? Why not 3 milligram?
Well, because you
1 milligram.
that's a very good question. So this I didn't invent a low dose slow infusion. It comes from the treatment of mechanical valve thrombosis, and we all know that there's a penalty of thrombolysis, right? It is intracranial hemorrhage,
Right.
and other bleedings. And with that regime, the event rate of the bleeding risk is very low and very controlled. And most of the patients with HALT are only mildly symptomatic, if symptomatic. So you want to treat either an echo diagnosis or mild symptoms in the majority of cases. And that is just the tip that I wanted to give you. There is another treatment option, that is the low-dose, slow infusion actylysis.
But may I comment on that, additional comment? I do agree, but you have to do it really slowly. I mean, at the very beginning, there were centers who did it faster, and that was too fast then because you have the problem of intracranial hemorrhage, as
by default,
as
these
Nicolas
patients
said.
are at high bleeding risk. Yeah? Yeah.
So that is, and here you have different patient cohort as compared to the ones that are in all these thrombolysis studies. There's a different patient cohort. They are 20 years older, so high risk for bleeding. So if you go now with a full dose, that's really effective, but super dangerous.
So in principle, the normal dose is up to 2 milligrams per kilogram over 2 hours. Yeah, you see, that's a very different regimen. I would not recommend to do that in these patients. That said, we are at the end of our session. We are over the hour. I think we discussed at length the phenotype of HALT and reduced leaflet mobility. We discussed how to diagnose it. CT is center stage. And we also addressed pharmacotherapy. I would like to thank Daiichi Sankyo and Biomedical for the support in this session. I would like to thank you for attending this session. I hope it was worthwhile. And thank you also, my co-panelists. And thank you for attending. Enjoy PCR.